Thanks to those who have already joined us today. We'll just give people another 30 seconds, a minute before we kick off the webinar for today. I think we will make a start because I know that speaking to the panel recently, that we've got an awful lot to kind of share and learn from you guys as well. So I will just introduce us today, and the title of the webinar is Reflections on Tracheostomy Care Since the Pandemic. We thought it would be a good time to kind of reflect on the last crazy couple of years and where we've come since that. For those of you who know me or don't know me, I'm Gemma Jones and I'm the chair of the Tracheostomy CEN. Thank you all for joining us today. With us today, we've got Helen Newman, who is on our committee and is going to be helping us with the questions and fielding the chat, should any of you have any of those. And we'd really encourage you to use the chat function today to help us kind of with any questions, to guide some of the discussions and that kind of thing. So please do join in. We've got lovely Sue McGowan, who is kindly going to chair this session for us. So I'll hand you over to Sue in a minute. We've got Sarah Wallace, officially OBE, fresh from the palace, joining us today, which is really exciting. And we've got Erin Ginelli over in the Royal Free in London, also joining us on the committee. So please do enjoy, do share, do take this opportunity to reflect on your own practice. And I will hand you over to Sue, who will kind of explain a little bit more about the purpose of today and what we're going to do. Thanks ever so much. Over to you, Sue.
Thanks, Gemma. The idea for this webinar came from discussions that we were having on the Tracheostomy CEN committee panel, actually, just in terms of reflecting on our own changes of practice in the last couple of years. What have we noticed? And we were having quite a lot of conversations, and we all thought, you know what it'd be really good would maybe to make these conversations public and garner feedback from you as we do, and questions from you. So thank you very, very much to Sarah, Erin, Helen and Jem for coming in today and for helping us out. We have got together 4 loose areas for discussion amongst the panel here. The first is what's changed in tracheostomy practice over the last 2 years, and then a few comments on aerosol generation, a section on what do we know about laryngeal complications, and then long-term sequelae. And then finally, hopefully, if there's time, we just wrap up with some thoughts about where we think we might need to go as a profession, based on what we've learned. What are the future perspectives looking like for us as a profession? What are the unanswered? What are the gaps? No, this isn't formal. This is very informal. There's going to be no slides, no PowerPoints. We are just using the expertise and knowledge and skill of the people who volunteered to be part of this panel, and you as participants, if you want to ask questions or put comments in. So Helen is going to be helping us also with the questions. So Helen, do I need to say anything more other than people put questions in the Q&A? Is that right?
Questions in the Q&A, and if you want to share some of your experiences, you can pop them in the chat or the Q&A.
And are we taking those questions kind of at the end of each 10 to 15 minute session? Okay, so the first session then is what's changed in tracheostomy practice over the last couple of years. Does anybody want to kick off on that?
I don't mind having a little kick-off. It's an interesting one, isn't it? Because actually the easiest thing is to say, you know, lots has changed, everything's changed. But I think if I reflect back on kind of very early in the pandemic, whilst there was an awful lot going on in terms of trying to get the right PPE and wondering about what was coming and all of that. There was also that kind of, we know our patients, and yes, we didn't know COVID at the time, but actually for me and my colleagues and some of my team, ICU particularly was familiar. And I often used to say to friends and colleagues who'd say, oh my goodness, I don't know how you're doing it. I'd be like, I'm actually going to work and I'm doing my job, and I'm wearing different clothes and obviously have anxieties around COVID. But actually the patients I'm seeing are the patients I would be seeing. And I think, so whilst I know we will go on and talk about all of the things that have also changed, I think there is also that kind of like, actually, we knew those patients were there. Now everybody else does. And yes, we're seeing lots of further complications and more delirium and exacerbations of things. But actually, we already knew it was there. So there was lots about it that felt kind of comfortable, and perhaps I felt a bit of a fraud initially, that actually I was just doing my job, whereas family, other colleagues, were getting redeployed and going elsewhere. So I think that from a kickoff is kind of something that didn't change in essence, but obviously then I'm very aware that lots of other things did as well. But I think that is a reflection I do often have about it. Yeah.
I mean, I couldn't agree more, Gemma. I count myself very lucky that actually I wasn't someone who wasn't familiar with ICU and getting redeployed, because that would have been hugely anxiety provoking. But I think it was actually quite an opportunity, certainly for the weaning team here, which is physio and speech language therapy on ICU. Whilst we were still doing the same roles, there was a lot more focus on us, and our profile was raised significantly, because all of a sudden we were thrown into a situation where the rest of the trust were getting incredibly anxious about the volume of tracheostomy patients that were currently on ICU, and they were worrying that how would the medical wards cope. And it was a really good opportunity to be able to work at that kind of level of the trust and say, we know how to do this, we do this all the time, we do it well, don't panic. So actually, that's another positive as well that I found that came out of my personal experience.
So I think I absolutely echo what you've both said so far. I think one of the interesting things was that we were actually able to stabilize some of the team at points, I think, because we many people were having to deal with tracheostomies for the first time in the MDT, not familiar with routine care. So we stepped up to provide that training in those difficult circumstances in full PPE and all of the communication issues that went with that. But obviously we had this huge surge in volume of tracheostomy patients, and huge everybody looking at how do we manage these patients with trachees? Do we have to completely change everything about tracheostomy care around how we wean patients, whether it's safe to use one-way valves or even deflate the cuff? So should we even be doing percutaneous tracheostomies, because that's aerosol generating? So the way that tracheostomies were being performed, the numbers of surgical trachees and perc trachees was thrown up in the air and totally reversed in some centres, and the weaning practice was also examined in depth because of the risks of aerosol to staff and to patients. So in some ways we had to go with the flow when everybody turned everything upside down, but we've come back full circle in many ways. We're back to weaning patients how we normally wean them. This whole thing of delaying cuff deflation created so many problems for patients around delaying their ability to communicate and swallow. But at the time, in the first wave in particular, everything was delayed, and weaning practice was totally changed. But we've learned so much from this huge numbers of patients that we've seen. Our learning curve is accelerated, and our knowledge and research has accelerated, and we're now putting that into practice again, I think. it's just been fascinating to see that whole team sort of look at how do we wean patients, and is, you know, should we be doing things differently? And actually the conclusion is no, early cuff deflation works and is the best way to go. And PPE protects you, so you know, stop worrying about it.
I think some of the other things that have changed and perhaps potentially delay is also the kind of impact of delirium. Delirium's been around in ICU for forever, and our knowledge of it has greatened, hasn't it? But I think that delirium that we've seen during COVID, because of the crazy suits that we wear, the environment's even worse, the kind of fear, I think we talked about, the kind of fear that for those people in the first wave that actually got it, it really has happened to me. What I've read in the press has happened, and lots of really really tricky cases of delirium, and their isolation, that they're not with their family and all of those kind of things, then impacted what we could do with them because of where they were at.
But it also gave us that opportunity, didn't it, to come into that role of assessing patients.
Absolutely.
Is it delirium or is it a communication impairment? And you know, I think even now our cohort on ICU of non-COVID patients and the increased acuity and complexity of those patients with delirium, you know, we have that enhanced role that came about through COVID, in that accessibility to sort of differentially diagnose, is it delirium or is it dysarthria or is it, you know, dysphagia or whatever. That's become, we've owned it, I think, is how I would phrase that.
One of you mentioned about the way that the whole team, you feel, has also changed. Sarah, I think that was one of the comments you made about working with the team and really integrating yourselves in team. And I think for me, that has been a real change that I've seen, that there's been much more team involvement. Does any of you want to talk about how that's impacted on either your ability to, or what you've changed in your communication intervention? So if I just kick that off, what I meant by that was I think I do a lot more now on just AAC stuff, you know, being aware of more patients needing AAC, number one. Number two, the importance, the massive importance of bringing family in to restore natural communication, synchrony between patients and and seeing that, giving you a much better idea once you see that interaction as whether somebody is really delirious or confused or just disorientated or a mixture of all three, or aphasic, as Sarah said. And I think that as speech and language therapists, I saw that we have quite a unique role in that, in impacting on helping patients and their families navigate the complexity of delirium, communication problems, and unpacking that and explaining it. Perhaps in a way, maybe we had a bit more time than colleagues did, but I think that was nice for me to see that we could be confident and be reassured that we did have a strong role to play in very natural communication, as well as looking at some more high-tech stuff, which
I had it was actually really, in the end, a really positive experience. So we were lucky enough at the Royal Free to have medical students and a team of virtual visiting organisers. So they would come around in the first surge and they would time plot everyone. So we didn't have to take that role with organising that. But I observed a session between a gentleman who was very confused, non-verbal, and it was between his son and daughter, and they didn't really know how to navigate or have an interaction, as opposed that wasn't dependent on verbal communication. And the two were medical students that were setting up the call also couldn't help. And so I gave advice for that particular moment, and then actually I offered to do some training to the teams that went round. So I think it really did highlight, like you say, Sue, what we have to offer, not just to the patients, but also in training communication partners and facilitators. So yeah, so that kind of wider approach that we can take to communication.
I also think that on the other side of things, the whole MDT's awareness of communication has massively increased. The fact that they struggle to communicate with patients through having to wear the PPE brought it to the front of their minds. So they're much more ready, I see now on ICU to initiate, use of AAC, for example, with a patient than they were before, or grab the iPad and set up a FaceTime call. I don't need to be the one always banging on about it all the time now. I'm there to sort of facilitate the more complex interventions, perhaps. But I see everyone now talking about communication as a priority for patients and staff, and talking and just having experienced themselves, the nurses and the doctors having experienced that nightmare of trying to communicate through the masks, and the family not being there to be the buffer, has given them that extra perception. And I think just they're initiating much more communication interventions with patients without me having to sort of say, well, hang on a minute, what about how do we get this patient talking? And one-way valves is the same thing. There's much more understanding about how they work, why we need to get patients talking early. I think it's just pushed that agenda hugely and really helped, but without taking anything away from us. We're still seen as the specialist, I feel.
Thank you, Sarah. I'm aware of the time. We've spent nearly 15 minutes on this one. Helen, is there anything that's come up in comments or questions about how our practice has changed or how practice has changed?
Yes, there's a comment from Lauren about similar experience to Aaron at the Royal Free. So they were able to develop AHP weaning protocols that included input from ICU consultants during the ward round. And it's felt like the MDT has gelled and become more of a team because of the experiences at the height of the pandemic. So that's, great to hear. Yeah, I was just thinking the general sort of well-being of patients, communication obviously highlighted importance of families. And I remember we used to get really excited if we could get a patient out of the unit and into the sunshine, because we could see that made such a difference.
Thanks, Helen. Thanks very much. And keep putting your comments and questions in the Q&A. So the next section is that we're going to be talking about aerosol generation and the things that changed our understanding of it and how that's also changed recently. So I wonder if one of you just want to kick off with what do we kind of know now about what aerosols are and how we protect ourselves?
Shall I go first?
Thanks.
Because I've been quite involved in all the PPE work that we've done with college. But I think what we've been battling, I think, on a national level with our government is around the understanding that this virus, among as many respiratory viruses is airborne. So it's not about an AGP as such. And I think the fact that the original diktat, if you like, from government was that we have a list here of, very small number of procedures that are considered AGPs, and none of the things that speech therapists do was on that list. Nothing about, nothing about dysphagia assessment, for example, was on that list. So, it caused all those difficulties and all of that urgent work that we had to do to try to protect our staff. But what we've understood and what the science has said for many months now, and in other countries around the world, they've all changed their guidance to reflect this, is that it's not about carrying out a procedure, it's the fact that this virus is airborne. It's there everywhere when you talk, breathe, yawn, cough, whatever, sneeze, all these things that happen. It's not about I put a valve on, therefore that generates an aerosol. So the new guidance that we've developed, and RCSLT, Kamini in particular, had led this push, which brought 20 professional organisations together who all have these similar issues and concerns for staff exposure, has led to the Royal College of Nursing really badging and launching the risk assessment framework, which looks at the environment that your patient is in, that you're in, and the risk to staff. And that has now been actually adopted only fairly recently by the government. But I think it needs a bit of a change of thinking again, because we've got used to talking about NAGP, and the fees, you know, is an AGP. What do we do? Do we do it in a side room, in a bay, whatever? And I think what we have to think about is looking more broadly at where are you, what you're doing, what are your risks to your patients, and wearing the appropriate PPE that we now trust, that we didn't know if it worked in the beginning and now we know it works. So yeah, I think it's important people look at that new risk assessment framework and are familiar with that, just to rein things in a little bit and to understand that it's not about a procedure that you do with a patient anymore.
So I think thank you. I think we've all received calls from people saying, oh, our trust is a bit iffy about me doing a cuff down on a patient, or ACV or EMST. How do we think we need to guide membership on that?
I think the conversations we've had are similar to what Sarah was just saying. I mean, it's about where you are and what you're doing and the kind of risks to everybody else. But I think we know that that restoring communication, restoring voice, restoring airflow is really important. So actually, the risk of not doing that is also should be taken into consideration. I think I have been perhaps lucky, you know, I work on intensive care mostly, but even on the wards, we are doing kind of business as usual now, because actually we are wearing the PPE. So actually for patients who are appropriate for cuff down one-way valve trials, we're doing it without any restriction on you know, timing of when that should be or duration of it. So, and I think that's when we were discussing it and thinking about it as a panel, that's what we were kind of saying we should really be pushing towards, is actually questioning why we're limiting it.
Yeah. Oh, sorry, Gemma.
No, sorry.
No, I was just thinking about our position here. We were during even the first wave, we took again a risk benefit approach. So we didn't categorically say absolutely no cuff deflation or speaking valves. We did it very much a bespoke model in agreement with the whole team. And we time limited it for 10 minutes. And there were some patients who were so agitated and delirious that the consultant said, I will take responsibility. You cannot take this. We cannot take this person's voice away from them. We are keeping that valve on. So I was in a very fortunate position there as a speech therapist, very supportive MDT. But now, when I'm trying to push us more back towards business as usual, I mean, it's great that risk assessment, Sarah, has been brought to my attention, because I was getting real resistance because there's actually been categorically nothing else kind of written that there's been a change. And my trust is quite they want that, well, certain members of my team wanted very clear, documented that things have changed now and we can be back to business as usual. So yeah, I've kind of gone from one extreme to the other in my trust.
I think if we can just signpost people to that guidance as well.
Absolutely
it's on
agree.
the RCSLT website, so it's easy to find, or you can find it under Royal College of Nursing Risk Assessment Framework for the virus. But yeah, I think business as usual is kind of been what we've been advocating for quite some time now. And I think, you know, up here in Manchester, where we've kind of just had wave after wave after wave, I think, you know, we've been still reverting to business as usual for quite some time. And I think like with the fees guidance, where we had to stop fees and then try to have emergency sort of guidance interim, and then business as usual right from, you know, 6 months later after first wave. But still people I know are struggling to reinstigate fees routinely, because people have got a little bit stuck or fearful, or I don't mean speech therapists necessarily, I mean in the trust that they work in. And I think we just have to keep pushing and saying, look, we've got the knowledge of the virus, we've got the PPE that protects us, we know how to do this. But we have to, as you guys have said, prioritize the patient.
Mm-hmm.
And it's so important that we look at their larynx. It's
Mm-hmm.
important we know what to do about secretions, or
Mm-hmm.
you know, are they safe to decannulate or not? It's important we have a look.
I think
Actually,
also
because
that
you've had to justify, almost make an extra justification why you're doing an instrumental assessment, it's actually highlighted the role and the value added from the findings. Sorry, Jem.
and I know this is only ICU specific as well, but I think it's often people lose sight of, we're all in the PPE that's used for, even if we are talking still AGPs, and the patients that are around the patient that we're talking about is also in a protected position, or actually has COVID. So, you know, like the risk of this isn't any additional to anything else. And I think it's those kind of things. I appreciate the ward is different, and I think that is where, you know, challenges do still, you know, that often the challenges mainly are, but certainly in an ICU environment, it's not. Yeah, we need to keep the patient focused, don't we, and what's right for those.
Sorry, just to add one thing that I will say within that first surge is, because we had so many members of staff that were redeployed into ICU, to have the weaning model that was not necessarily doing PMV in line, but was more when Tracheostomy started and incrementally increasing it in line with the Tracheostomy trials. Actually, not only at that point did we think that was safer from a COVID, but actually from a not confusing our nursing colleagues, it felt safe, not just in an AGP perspective, which is debatable now, but actually from a managing a workforce that perhaps hadn't worked with tracheostomy for years, let alone PMVs. It was just one thing that we were like, right, okay, this is quite clear, and in some ways in the short term a little bit easier.
Yeah, it was
Thank
almost
you.
like taking it back to basics, wasn't it? And also taking us back, you know, quite a few years.
Yeah.
Just to keep it all very straightforward. But now we're back to our sophisticated model of care.
So Helen, is there anything either that you wanted to add yourself, or from comments or questions that have come in?
We've had a couple of comments. So other people experiencing difficulties getting back to business as normal because of trust policies. Welcome to our MDT colleagues. Got a comment from a physio about how physio treatments were also limited. So at the beginning of the pandemic, there was a limited number of types of treatment, or quantity, I think, if I've read it right. But now PPEs trusted to keep people safe. But at one point, patients were limited to have, they had to have 3 negative PCRs before cuff deflation. So now, I mean, some people, that would keep them cuff inflated for a very long time.
Yeah.
We know that now. The other thought I just had was when you're trying to tackle policies and going back to business as normal, there's the added complication. You've got to liaise with so many different departments, so infection prevention and control, maybe outpatient services, and it's coordinating all the right people to say, yes, we can do this, or lots of people to liaise with.
That's really interesting about the physio comment. I think it just kind of supports everything, doesn't it? That we were all in the same boat. But I feel it's a bit like saying we were doing very protocolized care suddenly, and now we need to be back to individualized weaning. In a nutshell.
Helen, have you seen Anita's
I haven't read it yet, so yeah, go for it.
Do you want me to do it?
Yeah.
Just before we move on to the next section, I think just in the context of AGPs and how, so the question Anita Smith has written, thank you very much, is how are we managing patients with active COVID who'd benefit from a fees? What decontamination procedures are being taken, stacks, covers, etc. You
just follow your manufacturer's recommendations for your fees stack. We just wipe our DP medical stack down, and we do fees in the COVID ICU.
So there isn't. So there isn't a delay. You're not waiting till they're COVID free. We're doing it. That's when we are.
It's really important you don't do that.
Actually, that was another silver. I've got lots of silver linings, it would seem. That was another silver lining here, because pre-COVID, we used to do Tristal wipes and no autoclaving. And actually, because when we were allowed to do fees again, there was no way that I could make that COVID secure. And so I then worked with our decontamination team, and they were like, yeah, bring your scopes up here, it's not a problem. And it's been the best thing. It's so much more efficient using autoclave than the Tristal wipes. So yeah, another silver lining.
Fabulous.
Great. Okay, well let's move on. I think there are some more things about external mics that can't be cleaned, but I'm going to leave that for your IPC lady to help you with. The next big section then, here we are, 2 o'clock exactly, is laryngeal complications. So the kind of big theme is what do we know about laryngeal complications that we didn't know before? And as we kind of answer that as a panel, how has that changed our practice, what we do, what investigations we might suggest or contribute, what team members are we working with differently? Have we got to know any new drugs? Who wants to kick off on that one?
I feel like OBE Wallace needs to kick off on that one.
Well, gosh, we know so much more. I can't stop laughing about that.
Sorry.
We've learned so much, haven't we? I mean, this cohort of COVID patients who've all got damaged larynxes has been fascinating. And I think that blind spot period we had where we weren't able to use endoscopy initially in wave 1 was quite frustrating, because you could hear these patients were severely dysphonic, really dysphagic, and you didn't know what was happening. And then since we started doing fees again here, I've collected like this rogues gallery of laryngeal images of things that are you know, just quite interesting, because I think obviously just the prolonged nature of intubation and all of the granulation and ulceration that you see with that has been what, you know, things we've seen before, but not to this degree. And I know from various papers and a paper that we published as well, that every COVID, I've basically done a fees on every COVID patient with a trache, and every single one has got a problem in their larynx. But what was interesting is that most of them have got 2 or 3 issues going on simultaneously, like cord palsies and weird, what I can only attribute to COVID itself, but sort of cystic like lesions as well. So I think partly it's the virus and partly it's the intubation effects, and you know, the edema issues and all of those problems. We've I think just seen the sort of things that we were seeing normally in the ICU population, but they're more prevalent and they're more severe, and they're more things coexisting and lasting a while. And then obviously stenosis issues, which are more concerning. You know, we're getting studies out now which reporting higher rates of stenosis, you know, double the number of patients with stenosis that you would normally see post-tracheostomy, and airway issues, you know, complex airway issues. So it's been fascinating, and it's still emerging. And it's really helped, I think, us to, and our role with fees to be absolutely in the spotlight. You know, it's essential now. We've always said it was an essential part of our toolkit, but now everyone else thinks it is.
Yeah.
And then do you think that there's been a growing awareness of how those laryngeal issues massively impact the wean extubation success, etc., and then long-term stuff? Do you think that there's been a pickup amongst our team colleagues about the awareness of those? Because we've known that for years. It's not new knowledge for us.
No.
I'll let someone else speak about that.
I think certainly here, what has changed in the wider MDT is they very much see speech therapy as the lead into identifying and then kind of triaging them and signposting them off to ENT. So whereas before they might have been, the doctors might have been the ones that go, yeah, we'll refer to ENT, we're very much seen as the first line of identifying that and making suggestions and referring on as needed. So yeah.
And have any of you used CTs, head and neck, to help guide management?
I think it's a useful useful adjunct when we're trying to understand, perhaps say the extent of things, you know, edema or malacia or you know, airway obstruction below the glottis, because that's hard for us to visualize on fees. So it's another useful thing, and I think I would definitely recommend it often and talk to ENT, and you know, that subglottic above the trachea portion that you can't really see very well when you scope top down, and below that. Sorry.
Yeah, I have to say I hadn't really looked at a CT in any great depth at all, and I wouldn't claim to be an expert at looking at them even now at all, and I always do it with the doctor, but it's really, really interesting and fascinating just when you're thinking about the ratio even of the tracheostomy tube to the airway, to look at a CT and go, wow, no wonder that person's not getting voice, because there is barely any gap. And it's actually just been a really nice, I say skill in the loosest sense of the word, to be able to pick out the tracheostomy tube and scroll up and down and go, oh yeah, this is really helpful. So to anyone who's not done it, like I would say, just sit down and with one of your doctors and say, can you take me through this? It's really good, it's really interesting and helpful.
And I think it does add, as Sarah said, to the diagnostics, isn't it? Sometimes, I mean, you know, 9 times out of 10, we do see things on fees and on scope first, that then reveals, you know, further problems on the CT. But actually, sometimes we've had the other way. So actually, the fees, you know, it looks to all intents and purposes okay, or certainly doesn't explain the clinical picture that we're seeing. And again, a CT neck is useful in that scenario, to be like, oh, it's actually the bit that we couldn't see. That's where the issue is. That's why, and helps us explain, you know, actually why the patient is still struggling with one-way valves, or whatever they're struggling with, that actually perhaps isn't necessarily clear just from fees alone.
And that joint, you know, that joint scoping opportunity with ENT or with the intensivist and ENT and us, where we can actually look at the larynx, perhaps even, and then perhaps also down the trachea to see, is it tube position, is it tube size, you know, all those other issues that can be responsible for an obstructed airway and lack of voice or airflow. That teamwork has come together even more, I think. I've almost had to rein our consultants in to some degree, though, because they now say, oh, you're the airway expert, you know, we think we've got a problem, and they're wanting us to do airway assessments, and we're sort of saying, well, hang on, if you want to look at that person's airway and that's the main aim, and I'm not involved with that patient, or I'm not, you know, not ready yet to do my bit, then you go ahead, you know, and then you're doing an airway assessment. I'm doing something slightly different. I'm looking at the airway, but I'm looking at the airway in terms of function and weaning and secretion management and all of that. So I think it's just making sure we know where that line is to be drawn, and not getting above ourselves and sort of saying, well, yeah, I know about airways. Well, we do, and we do know a lot more than most people on ICU, but I think it's about making sure we don't get asked to do things that are slightly beyond our remit.
At the same time, there is an opportunity for coming together, as you said,
collaboration,
two people collaborating, seeing different bits of the whole.
And
Helen, you were going to come
scopes, I think, is the other thing.
Absolutely.
Helen.
Just questions come in, and tying into this discussion, who is it that is asking for the CTs? Is it there's a CT already there done for the chest and you're looking at the airway, or is it that there's a question about the trachea and a CT's done for that? Are SLTs asking for CTs? And what would be the indication for asking for the CT?
I've never asked for CT. I would say it's either there or ENT have requested it. That's my experience. Sarah, I know yours might be a bit different.
Yeah, and I think it's always that just team discussion, isn't it? Does this warrant a CT to see the bits we can't actually see when, you know, when I look, you know, down on the larynx, and I think that ENT input is crucial, but sometimes in reality can take a while to get that in opinion. So I think if we are struggling to, I suppose the indicators are you're stuck. you don't know what to do next. You don't, you know, maybe I've looked at the larynx and everything looks pristine. So, but there's no airflow. What are we going to do? Downsize the tube maybe, or just, you know, maybe you've done that already and you've still got a problem. So I think it's just talking through the options with the intensivist, physio, everybody involved in the Trache care around, you know, what else can we do to look and visualize it, some structural issue, or is it a tube size issue or type of tube, because we all know they're slightly different sized diameter.
Positioning. Yeah.
And then just
yeah.
sorry, just to finish
No.
off this section on laryngeal complications in the next few minutes, I think as a panel we wanted to touch on our experience of using Dex and or PPIs, and just have maybe one of you comment on how have you seen Dex used well in combination with PPIs, and for how long, and who does the review of that?
Well, I know most of our intensivists don't give a high enough dose of PPI, so I would fairly confidently say that most patients on our ICU are on a PPI as routine, but it's not the adequate dosage for reflux as I understand it.
And I think if you've done the scope and you've seen signs that it could be laryngopharyngeal reflux, then that's a go-to intervention, isn't it? It's to talk to them about, can we, I mean, there are contraindications to giving patients high doses of PPIs, but can we double the dose? Usually it's sort of BD instead of once a day that they're already on. And I think with Dex, the COVID patients have all had the course of steroids already.
Yeah.
And I think it doesn't always seem to work for laryngeal edema anyway. So and those steroids that, you know, cause a lot of weakness as well. So it's again that risk benefit discussion with the team around, is it worth another go? I think our dose recommended is normally 6.6 milligrams for 4 to 5 days. And then what we'd probably do is look for clinical signs of improvement in airflow, or voice starts to come, or, you know, start to be able to get some airflow out the mouth, and maybe rescope.
Thank you. Any more comments from either panel, or any questions, Helen, just on laryngeal complications and either what we've learned or new management or
Just
interesting observations?
A question from earlier, and that was just about the FEES Tristal wipes. So there was a question for Erin. What was it you were doing instead of the Tristal? Is it autoclaving?
Yeah, I use the word autoclave, but it's basically a centralized decontamination. So in our hospital, it's in a different building. You give it to the porters and they take it, and it gets put through a machine and given back to you nice and sterile.
Was that it, Helen? Anything else?
Yeah, no other questions at the moment, but keep them coming in.
Okay. Thank you, team. So we've just got one more area and then some closing thoughts. So obviously our colleagues who aren't on this panel or aren't on Trache CEN have written a lot about long-term sequelae for patients, and it's brilliant to see those papers in terms of the airway, stenosis, voice and swallowing problems long term. Certainly not my area, because I think most of us here are acute clinicians. So here's a plea: can we please have anyone who works in the community or in long-term settings come and join us on the panel? So question for you all is, what do we know now then about the long-term sequelae for these patients?
Yes. I can kick off if you like. I think we have got quite a few nice emerging studies actually with large data sets. So there's a paper that I was involved with Anna Miles, which has got data from, I think, 7 countries now, about the dysphagia and dysphonia consequences of COVID from ICU to community. So definitely flag that paper. We know that most patients get decannulated before they leave hospital, but that we've got higher rates of prolonged airway, voice, swallowing issues, and fixed airway obstruction issues. One paper by Neval et al. 2021 found fixed upper airway obstruction in 22% of patients. self-reported dysphagia persisting at 2 months post leaving hospital in 30%, and vocal cord problems that persist and stenosis issues 17% in one paper. So it's really, to me, it's key these patients have followed up. And I know from our experience here that quite a few leave hospital still dysphonic. They come back to us via critical care outreach. Patients are complaining of ongoing sort of globus type symptoms, hypersensitivity related problems where they feel food is sticking, or they've got, ongoing vocal fatigue. They're coming back to voice clinic, and they're coming back wanting their swallow checked, because at the time they left hospital, they were kind of happy. And then they go home, go back to daily life and find that these things become a bit more of a concern for them.
I've had
There are quite a few papers out there actually now, which we can signpost. Sorry, Jen.
No, sorry, sorry, Sarah, I thought you'd finished. I would agree. I've had seen exactly that as well. And I think those patients who have had such a long traumatic ICU stay, their voice or their swallow, they, as you exactly say, they're happy with it, aren't they, at the point of discharge? And actually you offer a checkup, a follow-up, a referral to outpatients, and they're not, they just want gone. And they're then coming back later and being like, actually, my voice doesn't work for this, or it's not great there, or, it's really fatiguing a lot of the time and really isn't working. And so it's those kind of patients as well that you didn't necessarily predict. Well, you probably could have predicted a problem, but they were happy with the problem, that are coming back as well. So
is it a plea also for speech therapists to be involved in long-term follow-up clinics? Yeah.
Absolutely.
We should be involved in that.
Yeah, which I think is a challenge, isn't it, because of resources and stuff. But I think there's definitely something to be, even if you're not present in every single follow-up clinic, to make sure that this swallow, voice, communication questions are part of the profiling that's done at those clinics, and that the consultants or the team that know who that then signpost is how I get them. So I'm actually not present at many of them. That there have been times where we have been particularly worried about certain patients, and know that the waits for X, Y, and Z are long, and we've kind of piggybacked into, because we've known they're coming to the clinic, is another way around it. But I think it's vitally important, isn't it?
I would also just flag here that don't reinvent the wheel, because those tools that we developed, the pickups tool, which has got swallow, voice and communication elements and cognitive communication aspects to it, is there, and the triage questions that other members of the MDT can ask to pick up these issues are there. Yeah. If you can't be part of that team, at least they can be asking the right questions.
I guess with more knowledge about the COVID sequelae in terms of the stenosis, though, we probably need to remind ourselves and our colleagues about what the kind of soft signs of airway stenosis are, so that it's not being confused with asthma or other acquired COPD issues. Helen, anything on that before we start to wrap up?
We've had a couple of people saying similar experiences with COVID ICU follow-up clinic, and just a request for papers. I was just going to put a link in for the pickups tool.
Thank you.
But yeah, we could probably send that out with an email as well, some references. But Sarah's put some references in the chat as well.
I can give you the whole references. Sally Archer's done a really good study as well, and Julie Reagan from Ireland has done a really good study as well. So there's actually quite a bit of evidence there if you're trying to make a business case for speech therapy in these clinics. And there's also the PHOSP or FOSP study that is happening at the moment, which has got a massive data set, which we are drawing data from. We've done a data request, and we're going to be drawing out data on patients' communication, voice and swallowing issues that will again be really helpful, I think, for pushing our agenda to be part of those clinics.
Yeah, or at least having a sort of smooth pathway into voice if they're flagged up by other MDT members from the follow-up clinics if SLT is not there at the time.
So Thanks, guys. What I've heard is that you know, we've really learnt loads about the benefits of early communication, and early input into these patients, about how our role in identifying laryngeal complications really early and management, and helping to influence the management of that either through investigative techniques or through tweaking discussions about meds. All help, plus our increased nuanced knowledge about aerosols and what the issue is there in terms of needing to really rely on, sorry, I've lost my notes, rely on the guidance from Royal College and from the Royal College of Nurse on risk assessment there. So there's more awareness of our role, and I think I've really enjoyed personally working much more with other colleagues more intensively on the units. It's great that we've got a whole stack of evidence base. So really the future's bright, isn't it? In that there's a lot that we can build on in terms of our improved knowledge and increased knowledge, and hopefully to better outcome our patients. But going forward, what would be, if I was to kind of ask you, what would be where you see the gaps are in our knowledge going forward, or what would be your wish list of things you'd want to see in 5 years' time come through?
Well, okay, I will say one of mine, which is I think the bit we haven't nailed yet is exactly what dysphagia interventions work best for these patients. We've sort of thrown all our usual compensatory and rehab exercises at them, and we don't really know exactly what works best for COVID, whether steroids help edema issues, and whether, you know, certain exercises are better than others, or whether, like, for one of the things we use, phagenics, whether that's a really key tool, because we've used that on some COVID patients and it's helped. So I think it's just really fine-tuning our ability to understand exactly what interventions to apply to different issues that we're seeing, and just, yeah, that would be my bit where we need to do a bit more research.
I think also on top of that, and we always come to staffing, and I definitely don't want it to bring there, but I'm very aware that there are still, you know, a lot of units nationally, including my own, who aren't sufficiently resourced, not even, you know, GPICs ready, but sufficiently resourced. And I think what's really reassuring and fantastic to see is the number of ICU critical care speech therapy posts that are cropping up and being advertised on Twitter and being seen. It's phenomenal. And just to keep up that momentum, because that, you know, without those colleagues, without those services, we won't be able to further develop our knowledge in those areas or the outcomes for patients, will we? So it's kind of the recognition, and for colleagues that are on the call, that is still very much a gap, isn't it? Not in knowledge, but in kind of the ability for us to do all of the things that we know we can be doing to benefit patient outcomes. But I totally agree. It's that kind of linking our diagnostics to what's best, what could be most effective.
And that's about being as absolutely efficient as we can be with, as you say, rightly, a very limited workforce.
Absolutely. Yeah.
What about, have we got any new diagnostic tools up our sleeve that we could maybe look into and think about? Ultrasound?
Go on, Helen.
Go on, Helen.
So obviously this is an area that is currently being looked at and needs a lot more research to validate and explore the potential uses of ultrasound. But we were talking about CT, the ability to be able to see below the cuff where the endoscope can't get to when you've got the inflated trachea cuff up. But the potential to a non-invasive for those patients that can't leave the unit for a CT or can't have an endoscope, to be able to use ultrasound to actually get a really good high resolution picture of potential swelling or pathologies below the cuff. That's quite an exciting area to explore in the future.
Is there anything you can point to for people to watch out in terms of ultrasound?
If anyone's on Twitter, the SLTs in ultrasound. My PhD uses ultrasound to measure the tracheal diameter, but not ready to publish findings on that yet, but that's quite exciting work. But there are more and more papers coming out on uses. So in head and neck cancer, they use ultrasound and correlate the findings well with CT and MRI. So I think it's got good diagnostic potential. And yeah.
We probably should just caveat that, Helen, with our ultrasound group put out a position statement through our CSLT to say it's not a tool for clinical use yet.
No.
So
no.
We don't want everybody running off to do
this
ultrasound.
is future, yeah.
But it is something that's emerging and is exciting.
Great. And anything else on your wish list that you could see accomplished in the next 5 to 10 years?
I would like to see, as much as they carry out CAM ICU scores and RAS scores, that they do a communication score, if you like, so that it's there on the nurse's chart. Oh, I need to, I need to rate my patient's communication. We haven't got that tool yet. I know Charissa Zaga is doing some work on her PhD with that I've been involved with, which is really, really interesting, trying to devise a suitable tool. But having that, it's kind of in people's minds, but it's not there in a concrete way, which I think would really help people understand how is the delirium affecting the communication and vice versa, and are we doing everything we can to facilitate natural communication, voice.
And that could also be a really valuable tool for research, and we're doing studies of what interventions work, and we have a core outcome for communication. That'd be fantastic.
One of my wish lists is near the top is to have much more patient involvement in designing services and in getting people back to help run follow-up clinics and educating the MDT on how delirium is. At the recent State of the Art Intensive Care Society conference, I felt a really good representation from patients in terms of diaries, writing how they benefited from diaries written about them, their contribution to their own experience of delirium. And I think the more we can listen to what it's like to be on ITU, this is really in the public eye. I mean, lots of, you could talk to any man on the street and they understand that patients who are sick are in ITU, and they kind of get what that looks like because they've seen it on Channel 4 News all the time or whatever news. So I think I think we could help to push the representation of patients into various research panels, but also clinics, policy making, etc. Jem, I'm going to hand back to you because we've got 2 minutes to go, but I wanted to thank everybody for allowing me to chair, because it means I get out of answering anything. And just thanking you all very much for this conversation and for the brilliant questions and comments that have come in.
Yeah, absolutely. So take this opportunity to thank you all for you guys. I appreciate there's a couple of things that haven't been touched on, so just come in fairly last second about business cases, and that's something that we have looked at and been requested on the panel or on the committee a number of times, which we will go away and have a think about how best to do that, how best to share those business cases, or how that might happen. And yes, I agree. There was the one about another kind of wish for 5 years' time is dedicated time for kind of QI and research. I think if we were in a position where we were funded appropriately and had, really that member of the team, that those things would come, wouldn't they? And it's great to see lots of our colleagues already that certainly sit with me on this committee and on this panel, and other colleagues nationally who are doing some amazing work, research work in critical care. So the tides are changing. Take this opportunity then, with a few minutes to go, to thank you all for joining us. We really appreciate your time. It's still a busy time. Thank you for all you're doing for the patients, for our services, for speech therapy generally. Please do keep chatting to us. We're a bit slower on our email at the minute. We realise we're trying desperately to find a more effective way to get back to you with all your amazing queries and inquiries and questions. So just bear with us. The next date for our webinar will be in a few months' time. Normally we have a date for you. For various reasons we haven't, but we will get it to you, so watch this space. And thank you ever so much to my incredible panel, as always. And yes, we will be in touch. And as Helen's put just on the end, as always, it's recorded and uploaded to our YouTube channel. So if you'd like to watch again, or colleagues who haven't been able to join us today can link on. If you give us a couple of days to get it there, it will be there. So thanks ever so much. Enjoy the rest of your day, and we will see you soon. Take care. Thank you.
Bye.
See you later.